Dr. Lee Schwartzberg.
Right.
It's an absolute pleasure to have you here, and it's really an enormous pleasure to have you with Join BCA.
Pleasure's all mine.
We're super excited about that. And I wanted to pick your brain on a bunch of things, but before I even get started, I wanted to highlight some of your accomplishments. You have spent an incredible career working and taking care of breast cancer patients, but you have also been a professor and division chief at the University of Tennessee,
right.
CMO of One Oncology. You've been on the board of the NCCN. You founded the American Community of Oncology Research Network, ACORN, right? Mm-hmm. ACORN. And you have an endowed research program at West Cancer Foundation and Institute that is named after you.
Yes.
That's super cool. And oh, by the way, you have 300 peer-reviewed articles chapters, which I know took an enormous amount of work. So tell us a little bit about your journey to get to the cancer world and to the breast cancer world. Tell us a little bit about that.
I was always interested in oncology, always liked high-stakes medicine, and I liked the research aspect of it. I trained at Sloan Kettering and actually took a big gamble after fellowship and went to Memphis, Tennessee, where I joined the West Clinic, which was 3 of us at that time. Bill West was the leader, and he is a visionary guy who combined clinical research and even lab research with clinical practice at the very dawn of community oncology. And over the decades, we were able to build a really great research enterprise in the context of a community oncology practice that grew. So at first, I really wasn't necessarily focused on breast cancer. I actually trained under a hematologist and a leukemia doctor at Sloan Kettering, and I thought I would do that, but I really got interested. We did high-dose chemotherapy in the 90s, and I was responsible for writing the protocols for breast cancer at that time, and I got interested then. I went to my first San Antonio conference in, I think, 1994. So it's been quite a long time. It was a little conference in the Marriott at that time.
God. And now
right.
It's enormous.
And I got more and more interested, and I focused for the last 20 plus years solely on breast cancer.
Yep, amazing. So let me ask you this. What do you see as some of the major trends that are ongoing in therapy for breast cancer patients?
Well, I think right now we're in an era of thinking about both personalized medicine more than ever before for every individual breast cancer patient, be it surgery, be it radiation, be it systemic therapy. We have a number of tools, and the tools are getting better in order to determine who needs what and who doesn't need what. And as you know, we're in an era of thinking about de-escalation. And it makes sense, in the 90s when I was first starting in breast cancer, we ran these huge adjuvant trials, thousands of patients, and we got better results. But today, you can't run those large trials because the increment, thankfully, at least in the early stage patients, to get better would require, if we treated everyone with huge numbers, it's not doable. So we've gotten smarter instead of bigger, and we can now do trials on cohorts of patients that are more alike than not, and we understand some of the biomarkers that are important in terms of tailoring therapy. So I've been, for the last 10 years, I've been really interested in precision medicine and looking at a variety of tools to enhance the patient experience, and I think that's where we're going.
It has always amazed me when patients will say to me, I don't understand, my friend got treated like this. And I always have to say, and it's true, I've never met a patient that's the same.
Right.
Whether it's their personality or their priorities, every patient is different. So the concept of tailored care that has to be the way it goes.
And even when, just as you say, even when the tumor looks, at least in terms of its histology and biomarkers, the same as another tumor, the underpinnings of the patient, what's important to them, what they can accept, how they can tolerate things, what their ideas about cosmesis are all completely different. It's one of the most fascinating things about taking care of patients.
Yep.
That's what I still love, seeing patients.
Yeah. So in talking about this kind of level of complexity, I can imagine that in particular, so for medical oncologists, surgeons don't have that many options. You guys have a lot of options, incredibly complex. How do medical oncologists or let's ask this question, what are the most common pitfalls do you see? Is it that they don't give enough options? Is it that they give the wrong options? Tell me, what are some of the pitfalls and problems that you see with other medical oncologists that are not as gifted or as educated as you are?
Well, I think the problem today is it's an embarrassment of riches, and it's very difficult to be a medical oncologist in the community setting in particular, where you're focusing on more than one or two different types of cancer.
Yeah.
Obviously, as students of breast cancer, as we are, we know the entire scope of it to a certain extent, and we know where to find it. It's really it's almost impossible for me to conceive that someone's going to see a breast cancer patient and then see a lung cancer patient and then see a sarcoma patient, which is a whole other group of rare cancers, 100 different molecular abnormalities, and then see a blood disorder that's not cancer. But that's what hematologists, oncologists in the community do.
Yeah.
In some degree, there is differentiation now in larger practices. Practices have consolidated, and people sort of have a major and a minor. But it's really hard. You have to use the search tools that are available. Problem is that you're busy, you're seeing a patient every 15 minutes, you might not have time to really get into it. And experience does matter somewhat, not necessarily on the first treatment you might offer, but once there's branching and you haven't had experience with all the branches, that experience is so essential to at least recommending to a patient what we think the best choice is and what the pitfalls are. So I do endorse trying to subspecialize if possible. I understand it's not possible in rural areas, in practices where they're small, even in urban areas, but at least I recommend using the tools. The NCCN guidelines are great. That's a great place to start. You can find almost anything in the literature pretty quickly. Really, time is the biggest factor.
Do you see any role, this wasn't on the list, but I'm curious, do you see any role in AI at some point helping in decision making?
100%. And I think this is one of the particular cases where generative AI actually works already to a certain extent. It needs to get a little bit more focused and specific. If you ask general questions, it's probably more about the way you ask the question than what it's capable of doing, so you have to learn some facility with that, and I wouldn't call myself an expert in that at all, but I've seen people who can do that adeptly and get good answers from AI. And I think that will be one niche of AI, just like we're using it in imaging and in pathology. I think in supporting treatment decisions, be able to search literature and sort of prioritize for you so you know what's going on. The other place that AI is making good inroads is by integrating all this genomic information. So the clinical information from the EMR with the genomic information to help you make an informed decision. Because breast cancer is actually a little behind some other cancers in terms of the scope of targetable genomic alterations, but they're coming faster now. And in lung cancer, there's about 15. You have to think about the day you see the patient. First-line therapy. So we're not quite there in breast cancer, but I'm sure it will.
But we are finding more targets.
But we're finding more targets.
That is very good news. I love hearing that. Well, tell us too. So you have now joined BCA.
Yes.
And give me your thoughts on how you think you can help breast programs with your expertise and experience through BCA.
I'm very excited that you're doing this initiative. I really am very happy to play whatever role I can in it. I think my personal experience is really helping to build 3 breast centers that over the years, starting about 25 years ago at a hospital-based system, then in a private practice, and now at another hospital-based system.
So you've seen it all.
I've seen a lot. Yeah, you get old enough, you see a lot.
Yeah.
And I think I know some of the pitfalls of where programs should direct their efforts and where they shouldn't.
Mm-hmm.
And I think encouraging the multidisciplinary team to work together, whatever the setting is, they're all different. You've seen one,
Mm-hmm.
but there are commonalities that I think we could come in and advise people about the best way to do it efficiently and not have to go down a lot of roads that don't pay off.
Mm-hmm. Fabulous, fabulous. Well, again, I can't tell you how excited we are to have you on the team. You're just such a valuable asset, and I think the programs that you're going to be able to help is going to really impact on the care nationally that we can deliver.
I can't wait.
Yes,
Let's
good.
do it.